are the negative of the physician-assisted suicide, and I'm going to just refute some of Aaron's points. He made a claim that physician-assisted suicide, or PASS, is ethically sound. However, it contradicts the core ethics of a physician. They take a Hippocratic oath when they become a doctor. The classic Hippocratic oath has the phrase in it, "I will neither give a deadly drug to anybody if asked for it, nor will I make a suggestion to this effect." So this was in the original Hippocratic oath, and that clearly states outright that euthanasia or physician-assisted suicide is not okay for a doctor to perform. However, there is a modern Hippocratic oath which is taken today. But it also has the phrase, "Above all, I must not play God." And I feel as if for a physician to be able to take someone's life or choose when someone's going to live, or I guess assist with someone in choosing when they live, that's playing God, and it should be left up to nature to when someone should die or not. Physician-assisted suicide also gives doctors too much power. Monica Ardelt, she wrote an article called "The Physician-Assisted Death," and it says that patients might not be able to trust their doctors completely if doctors have the power to take their patients' lives, particularly in cost-saving climate for physicians. So doctors can't be, well, you'll never know if a doctor can be trusted, especially when it comes to things such as cost efficiency and stuff like that for themselves. Also, physician-assisted suicide is not the same as signing a DNR. Aaron made the claim, or Aaron pointed out or defined what passive physician-assisted suicide is and active physician-assisted suicide is. There's a fundamental difference between, a DNR, by the way, stands for Do Not Resuscitate Form. So it's not, a physician-assisted suicide is not the same as signing a Do Not Resuscitate form. There's a fundamental difference between refusing life-sustaining treatment and demanding a life-ending treatment. The right of self-determination is a right to accept or to refuse offered interventions, but not to decide what should be offered. The right to refuse life-sustaining treatment does not automatically entail a right to insist that others take action to bring on death. And that quote was from the American Medical Association. And it just shows that signing a DNR isn't the same as a physician assisting with suicide. Karen also made the claim that physician-assisted suicide is mainly for the purpose of the comfort and preference of the patient, but it is in fact that not all patients want to die that way anyways. In the article from Monica Ardelt in the physician-assisted death, 60% of patients 65 years or older, when they were asked if they supported physician-assisted suicide, they said no. However, 60% of their family members supported it. The article also stated that family members are faulty in guessing whether or not, guessing their family member's preference. And the reasons to commit physician-assisted suicide would not result in a peaceful death, but rather a bitter one. The Evolving State of Physician-Assisted Suicide, which is an article that was in The Atlantic, says that the three leading causes of end-of-life concern, or the three leading end-of-life concerns is they cited loss of autonomy, loss of dignity, and the fact that they were less able to engage in activities making life enjoyable. If someone were to die with those feelings in them, I would argue that that's not a peaceful and comfortable death. That's a very bitter death. Also, physician-assisted suicide does not always serve the patient. In the New England Journal of Medicine, the investigators in the New England Journal of Medicine, when talking about the investigators minimize the number of patients put to death who have not requested it by omitting this category cases in which patients were given pain medication without discussion of the doctor's explicit intention to use the medication to end their lives. This is talking about when physician-assisted suicide was made legal in the Netherlands. It says that these deaths have increased by 40% from 1,350 deaths, 1% in all deaths in the Netherlands, in 1990 to more than 1,900, 1.4% in 1995. a comparison the investigators choose not to make. In over 80% of these cases, the patient made no explicit request for death.